Hello, thank you. Welcome, everybody. Um, Today we have Dr. Thor Halfdarnason from Mayo Clinic here in the lovely state of Minnesota. He's one of our neuroendocrine experts, and he is here to present to us kind of the latest in what's going on with neuroendocrine research and treatments for patients. So I think without further ado, we're just going to let Thor take over, and we'll go from here.
Thank you very much, and yeah, thanks for the opportunity to meet with you virtually. Hopefully, one day we'll be able to meet in person again. But so what I wanted to do is maybe for the next 45 minutes or so, talk about some of the advances in neuroendocrine tumor management, and briefly introduce you to the Mayo neuroendocrine tumor team, and talk about some of the clinical trials that we have. And if you have any questions anywhere along the presentation, feel free just to raise a hand or put a comment in the comment box there, and we'll try to address all of the questions. I want to make sure that this is not sort of an event where I just go on, drone on, and no one asks questions. I want to have it as interactive as possible. So I'm going to see if I can share my screen, and it looks like I can. So let me just set up my presentation. So hang on a second, and I'm going to put it in presentation mode here. And we should be ready to roll. And so now you should be seeing my introductory slide, and let me know if you're not. So some of this may be new to you, especially if you've gone to any of the NCAN meetings. So I'm just going to go through that fairly quickly. Obviously, in 45 minutes or so, we won't be able to cover everything and anything within neuroendocrine oncology, but we'll do our best. So one thing I wanted to just raise awareness of is that the nomenclature, the naming is changing a little bit, and some people have actually picked up on this. And so we're talking about neuroendocrine neoplasms, or NENs, instead of NETs. So a neoplasm is just a more inclusive term that includes both well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. And it's everyone knows what we're talking about when we say NETs, but it's just more inclusive. And some of the folks with high-grade neuroendocrine carcinoma felt like they were left out if we were just talking about NETs. So, and what are they? And you obviously are all familiar with this, so I'll keep this short. So cancers can arise anywhere in the body, and extremely heterogeneous. So it's, as I always say, it's almost as if no two neuroendocrine neoplasms are the same, and it's everyone is unique in their way. It's not like some other cancers that are more sort of each case is very similar to the next case, but the NETs are very, very different. And just because they can arise anywhere within the body, they can present in such a variety of ways. And why do we get the NENs, or neuroendocrine neoplasms? For most of the parts, we don't really know. So as I'll show you here in a few slides, we're definitely seeing a lot more of these, and I am just not sure why. And we don't really understand a whole lot about the risk factors. So some of the pancreatic neuroendocrine tumors, the well-differentiated tumors, maybe 10% of them or so, are related to certain syndromes that might run in families, most commonly a syndrome called MEN1, rarely a syndrome called von Hippel-Lindau, or VHL, and the others are even less common. And then we also know if you have a small bowel neuroendocrine tumor, your siblings or children might be at the 5 to 10-fold increased risk of getting a small bowel neuroendocrine tumor. But because of the risk in general being so low, that even if 5 times a small number is still going to be a small number. And of all of the patients I see, here at Mayo, we probably see several hundred new cases per year. We rarely see this in families, but as some of you may know, there are families out there where a lot of people have neuroendocrine tumors, and they don't have a syndrome, and we don't know why. There have been some studies, one from Utah, suggesting that there was maybe clustering around like mining towns and the mining sites, but that's never really been shown. There's an older study from Sweden suggesting perhaps certain occupations, especially in the chemical industry, where people were exposed to certain chemicals, but that really never went any further. So we don't really know. So, and how common are NENs? So people say that this is a rare tumor, but it actually is not rare. And I'll show you here in a little bit why that is. And we're seeing more of them. So this here, I've shown this slide many, many times before. So what we're looking at here, I'm going to make sure if anyone is monitoring the chat and wants to stop me, just let me know. So. And so here on this graph, we're seeing the trends in cancers in the US from 1973 to about 2012 or so. And in this this top line, the blue line, this is the number of all cancers. And you can see that in the 70s and 80s, we're seeing a little bit of an increase in cancer in general. And then it seems like we turned the corner in the 90s, and now we start seeing a little bit less of cancer. Now we're like counting like breast cancer and colon cancer and lung cancer and prostate cancer and whatnot. So I think this decrease in the total number of cancers, as per this blue line here, is because folks are smoking less and maybe getting a lot more screening for colon cancer and breast cancer and other cancers, and that's probably what we're seeing. But the orange line, as you can see, is going in the other direction. So this is the number of neuroendocrine neoplasms. So not so common in the 70s, and it isn't until like in the mid 80s that we start seeing an increase, and we're seeing this go up and up and up, and more cases are diagnosed every year. And now we have about 7 cases per 100,000 per year. So the way, and that's called a tumor, the incidence. So it's a number of new cases over a certain period of time. And living in Rochester, we roughly have about 100,000 people in Rochester who live here. And I tell my patients oftentimes that means that we're expected to see 7 neuroendocrine tumors in patients just living in Rochester alone. And then if you multiply that by the number of people living in Minnesota, obviously that's a much bigger number. And these tumors are most commonly in little lung, small bowel, pancreas, and rectum. So one of the reasons we're seeing this increase is that a lot of people are having screening colonoscopies now, and we're picking up rectal neuroendocrine tumors that were previously not picked up. People didn't know about them. Some people probably lived with them their entire life and never knew. Same thing with stomach neuroendocrine tumors. But if you sort of zoom in on so there's a 7-fold increase if we look back to the early 70s. And if you look at the different tumor types, and I'll break this down for you. So for example, this line here, this dark blue line with those diamonds here, this is the lung cancer or the lung neuroendocrine. You can see that in the 90s, we started seeing a lot more. I think some of this is that people were just getting more scans, like screening for lung cancer and things like that. Just more scans being done, we're picking up more tumors. Some people probably would have lived their entire life with a lung neuroendocrine tumor and never known about it. If we look at the small bowel, we can see we're seeing more of small bowel, we're seeing more of rectal. I think that's almost entirely due to increased colon cancer screening, where we just find these incidentally, and we find a rectal cancer in about every 1,000 to 2,000 colonoscopies done for screening. We'll find a rectal neuroendocrine tumor. So it's not common, but it's not super rare either. And then the pancreatic neuroendocrine tumors. And so why is this happening? And as I said, we're getting more endoscopies, we're getting more scans, and there's better awareness. So now clinicians, physicians, advanced practice providers, nurse practitioners, PAs are just more aware of this. I think that's a part of it, but there also seems to be a little bit of an increase. And not shown on this slide is a a study that just got published a few weeks ago from England, and they looked at the neuroendocrine tumors in England, and they're seeing exactly the same. So we're seeing more of it. But now they found that neuroendocrine tumors, in terms of prevalence, which is the number of people living with a neuroendocrine tumor or survivors of neuroendocrine tumors, that number has gone up so high that this is now the 10th most prevalent cancer in England. And of all of the abdominal cancers, only colon cancer has a higher prevalence, meaning where there are more people diagnosed and more people living with this. So neuroendocrine tumor now, they're now more common than pancreatic, adenocarcinoma, stomach cancer, esophageal cancer. So this is it's not a small problem. So I'll quickly go through tumor grade and differentiation, because that's another question I often get. So people ask me, so what is the difference between a tumor grade and the differentiation? And the tumor grade is really just to give us an idea about how aggressive neuroendocrine tumors may be. So we can have a grade 1 neuroendocrine tumor that's really slow growing, or we can have a grade 3 neuroendocrine carcinoma that is much faster growing. And we decide on this tumor grade using this system called Ki-67. It's a tissue stain. We stain the tumor tissue, and the stain only sticks to tumor cells that are growing or dividing. And then we count the number of the cells and come up with a percentage, and we can say how many of the tumor cells in this specimens are actually growing. And the way this looks in the microscope for the pathologist, this is a grade 1 tumor. So you can see this in this sort of sea of little blue dots here. So these are the neuron tumor cells, all these little blue dots. And we can see 1 and 2 and 3 and 4 and 5 little brown cells. These are the positive staining cells, less than 3%. So this is a grade 1 tumor. On the opposite side here, we see a grade 3 tumor, and here we can see almost all of the cells are picking up that brown stain, and means that they're almost all actively growing. And this would be typical for a neuroendocrine carcinoma. But most people are somewhere in between, with grade 2, where less than 20% of the cells are actively dividing. And then it gets a little bit more complicated, because the grade 3 neuroendocrine tumors, they can be actually, some of them can be very surprisingly slow growing, and others can be amazingly aggressive and fast growing. And that has to do with what's called differentiation. So not just the Ki-67 number, but the way that the cells look in the microscope. And this is where we really need a good pathologist, someone who does a lot of looking at the samples in the microscope. Mm-hmm. And how do we decide on the differentiation? So this really means that we are sort of just looking at the cells, how they look. Do they look sort of all the same sizes, or do they look like different and angry and in different sizes and shapes? And the way I sometimes express this is that they can be all sort of well-behaving, dormant, or they can be really aggressive looking. And all of the poorly differentiated tumors are grade 3, but not all of the grade 3 tumors are poorly differentiated. And that's actually where things get often mislabeled. So this is where I see patients who are being told that they have a poorly differentiated tumor, and maybe recommend that they get a really aggressive chemotherapy. But when we look at it, we see, yeah, it's a grade 3 tumor, but it's not poorly differentiated. It's actually well differentiated. You don't need this aggressive chemotherapy. So that's where the pathologist comes in. The other thing is the stage. So that's probably the most important factor that tells us how a person is going to do over time. So this is just sort of the framework that we use here. So stage 1, we almost never see stage 0. And stage 1, it's like really localized. Stage 2, it's a larger but localized tumor. Stage 3, it's typically into lymph nodes. Stage 4, the tumor cells have actually left the organ they started in and gone somewhere else. And the way that looks is something like this. We have stage 1 and 2 limited. This is the colon here, just for an example for colon cancer, limited to the colon. Stage 3, now it's in the lymph nodes outside of the colon. Stage 4, now it's in the liver or lungs or bones or somewhere else. So that's how the staging works. So I was thinking I could pause here just to make sure that we don't have any questions, or and then I'm going to talk a little bit about the Mayo NET program, and then talk about some of the advances and some of the new trials that we have. So any questions from anyone? If not, I can just move on. So the Mayo NET program, some of you are familiar with, but what a lot of people don't know is that we've had this program for a long time. So I came to Mayo in 2003 to do my training in oncology, and there was already a well-established neuroendocrine program here that goes back to the 70s. And wasn't really much sort of advertised in a way. And a lot of the early key clinical trials in neuroendocrine tumors were done here at Mayo. I see there's a question that just came through here, and apparently there might be some issues with unmuting, but that's, we'll try to address the questions in the chat. So how often is the staging done? That's a great question. So depends on the situation. So if you or have someone with a metastatic neuroendocrine tumor or neuroendocrine carcinoma on therapy, we may do the staging every 3 to 6 months. If you have undergone surgery for a neuroendocrine tumor that's now gone and there's nothing in the body suggesting neuroendocrine, then we may do staging every 1 or 2 years. It all depends on the extent of the tumor and the tumor grade. But typically for stage 4 aggressive tumors, staging every 2 to 3 months even. For stage 4 slower growing tumors, staging every 6 to 12 months. So moving on to just back to the Mayo program here. So and we're certainly not the only place in the country with program for neuroendocrine tumors. There's a lot of really outstanding programs there, but we're probably the largest program in the upper Midwest now. So, and the need for a neuroendocrine tumor program is that these are really complicated tumors, as many of you know, and they require a lot of different teams. So there are multiple teams that make up the big neuroendocrine tumor team. So it's medical oncology, that's us. There's surgery, that could be abdominal surgery for the pancreatic and small bowel neuroendocrine tumors, could be thoracic surgery for the lung neuroendocrine tumors. Then we need radiology, because without radiology, we're totally blind. So they are the ones who provide the diagnostic imaging, but also increasingly the treatment now with nuclear medicine, with PRT or Lutathera, and then interventional radiology with embolization. So radiology is really absolutely crucial. We have gastroenterology, often needed to make a diagnosis and help with nutrition and managing diarrhea, but also to get the tissue from the pancreas, fix bile duct blockages and things of that nature. Pathology is another crucial specialty like radiology. Without pathology, we're blind. And if I can't trust my pathologists, I cannot recommend on the best treatment. So, and if the pathologist tells me the wrong thing, and I might actually give the wrong treatment or a less appropriate treatment. And that's why it's so important to have a good pathologist. And what happens here at Mayo is that if the pathology is challenging, they really have several pathologists look at the sample. And then we have the lung specialists or the pulmonologists, radiation oncology, and then cardiology and cardiothoracic surgery, which is mostly for the carcinoid heart disease. So I wanted to show you the medical oncology team here. So this is the clinical provider. So Dr. Halfdarnason, my colleague, myself, Rachel Eyring, who's our PA, who's been doing this for many, many years, and many of you know. Morgan Miller is a nurse practitioner who joined us actually probably a year ago now or more. She's really outstanding. And then we have a couple of nurses who work with us, and then nutrition and social work. And I'm actually going to stop my presentation here because I didn't tell you that I am actually on call for the hospital and I just got paged. So I'm going to mute myself and turn off the video, but hopefully within the next 5 minutes, I'll be back on.
Do you want to ask him those questions that you just asked us?
Well, I can.
Okay,
so, hi, Dr. Thor. Hello, this is.
Hello.
And, I'm wondering about this new clinical trial drug, this cabaz, I don't know how to pronounce it.
Cabozantinib?
Yeah, yes. And then it's supposed to reduce tumors by 30%, but it's also experimental. So I'm wondering, is that true? I mean, I don't know. What do you know about that?
No, it's a great question, and actually the phone call I just took was on this study. So
Oh,
so I know the study very, very well. And so this is a drug that's approved for thyroid cancer and for kidney cancer and some other cancers too. And so there was a study a few years ago, small study from Boston that looked at cabozantinib in patients with neuroendocrine tumors, and it found that it did shrink the tumors, probably not quite in 30%, but a lot of people were able to stay on this drug for many, many months and even years without the tumors growing. And in neuroendocrine tumors, oftentimes our goal is not necessarily to shrink the tumor, it's keeping it from growing. So, for example, in patients with pancreatic neuroendocrine tumors in this small study, there were 30 patients with pancreatic neuroendocrine tumors, and they were on average able to stay on the drug for more than almost 2 years. So this everyone thought was really, really promising. And so it was decided that by the National Cancer Institute that this was worth further study, and they created this big trial called Cabinet, and it's a really big trial. There will be 400 or 500 patients on it. And in this trial, 2/3 of patients with the growing neuroendocrine tumors will get the cabozantinib, and 1/3 will get placebo, so ineffective drug. Then we will compare the two groups, and if those who got placebo have tumors that are growing, they can then switch over to the cabozantinib. And what we're going to do, we're going to measure how long people can stay on this trial, and also going to try figure out how easy or hard it is to stay on this study. So this actually might be a drug that will eventually get approved. And we know that similar drugs from this class do work. There's a drug that some of you may be familiar with called Sutent or sunitinib that's used for pancreatic neuroendocrine tumors. It's probably not the best drug from this class, but it happens to be one of the oldest and earliest drugs from this class. So that's why we have it studied already. So this cabinet study hopes to improve on that. So that's what that is. I hope that was a long answer.
Okay. Thank you. How about immunotherapy? Are NETs patients being treated with immunotherapy?
Yeah, great question. So the immunotherapy for well-differentiated neuroendocrine tumors has been a great disappointment. And immunotherapy, essentially medications that stimulate your own immune system, so the immune system can now recognize the tumor cells and kill them. For neuroendocrine tumors, doesn't seem to work. So, and as I've sometimes said, the neuroendocrine tumors don't care much about the immune system, and the immune system doesn't care much about the neuroendocrine tumors. So it seems like they live in these totally separate worlds. And the only exception is high-grade neuroendocrine carcinoma. That is where immunotherapy can at times be incredibly effective. But for the well-differentiated neuroendocrine tumors, there have been now 6 or 7 trials, and typically less than 5% of patients will respond. Some will, and I think what we might do eventually is to try it in people with well-differentiated grade 3 neuroendocrine tumors. That's where there might be some activity, but we just don't know yet.
Okay. I read recently thank you. I have another concern too. It was about a book I read recently where it said that most of the time in clinical trials, they don't have placebos.
Yeah. So
I forgot the source. But
yeah, so that's very true. And in neuroendocrine tumors are probably one of the few tumors that are left where we have placebo-controlled trials. And partly because most neuroendocrine tumors, as many of you know, are very slow growing. And we really want to know if the drugs are effective, but it's not just that. It's also because for a lot of people, we don't have another active drug to compare to. So it's been those two reasons we're going to be seeing, and when I get into the second part of my presentation, I'm going to show you a number of new trials that just opened at Mayo or will open in the future. Not a single one of them will have placebo.
Okay.
So this actually is changing.
Okay.
Yeah. So
Thank you.
I think Cabinet is the only study I'm aware of right now that has placebo.
Oh, okay.
And the whole idea was that the National Cancer Institute really wanted to know if this drug was active at all, and I think it will be.
Okay. How about controversy of CT scans and radiation? I had heard at some coffee clutch, it was regarding neuroendocrine tumors. And I thought I heard, but I don't know if it was correct, that really because of the radiation that they weren't recommending more than 3 CT scans in 1 year. Is
Yeah.
that
So yeah.
Mm-hmm.
Great question. So it's each CT scan has a little bit of radiation to it. So and radiation, if it builds up over time, can be harmful. So the radiation with a CT scan is actually getting less and less as our scanners get better, and so we need less radiation to get better pictures. So and we think this is really most appropriate for children and young adults with cancer, because they might have 30, 40, 50, 60 years ahead of them where they need scans. And that's where this really builds up. For those of us who are beyond 40 or 50, this probably, even 3 or 4 CT scans a year, will probably never cause any problems. Because the time for this radiation, if it causes harm, is probably would be over like 40 or 50 years. But that said, we are moving more towards MRI. And a lot of my younger persons now are being scanned with MRIs. And MRI is just a giant magnet. It has no radiation. It's an uncomfortable scan for many, I will say, but doesn't have radiation. So we're going to be moving more into MRIs. But sometimes, especially with a PET MRI, we're just having a hard time getting insurance to approve it. And also, the MRIs are really fantastic for the liver. But if you're looking at things lower down in your abdomen and your pelvis and things like that, that's where actually a CT scan might be better. So a tiny risk from a CT scan, you have to weigh that against the risk of doing a study that's not nearly as good and missing something. So, but it's a good question. We're very, very mindful of this.
Okay. Okay, thank you.
You're welcome. So I see a couple of questions in the chat there, and so the CAPO study. What kind of side effects are we seeing? And this is a really good question, because these drugs are not they are not without side effects, and I'm going to be perfectly honest with you. So what we're seeing is high blood pressure is the most common side effects from cabozantinib. And we're seeing some people get skin rash. We're seeing some people have problems with the liver numbers. We're seeing some people get tiredness. So I will say that probably about 40 to 50% of our patients cannot tolerate the full dose of cabozantinib. That said, we can almost always find a dose, either like a half a dose or a third of a dose that people can tolerate. But I will not try to sell you cabozantinib as a drug free of side effects, because it's not. But we have had now a few people on the Cabinet study for over a year, and some of them have had minimal problems. But a lot of them we have had to drop the dose.
Okay.
And that's what we do with the trial. So moving on to the next question. So, and here's one from Rec, and comment regarding histotripsy. So histotripsy it's a relatively recent technique used to destroy smaller tumors, and it's an interesting, very interesting technique, but it's not widely available, and it's to this day very poorly studied in patients who actually have cancer. So I think we'll see more data on histotrypsy. I could see how histotrypsy could be used in the future for patients who have very small and localized tumors. For patients with many metastases, I'm not sure if histotrypsy will be a good option. So something that I think we're going to see a lot more of. And then Kathy has a couple of questions. I wonder if you would just have you unmute and ask questions.
Okay, I think I'm unmuted. One is a CT scan every 6 months of the thoracic, abdominal, and pelvic area. Is that a substitute for a mammogram?
That's actually a good question, and it's not. So we got some idea about the breast density, and we can pick up. Sometimes you can pick up tumors in the breast that way, but in terms of replacing screening mammograms, it does not. So I tell all of my women, even women with metastatic neuroendocrine tumor who might be expected to live many years, I tell them, stay on top of your screening too, and get your mammograms, get your colonoscopies, check your blood sugars, check your cholesterol, your blood pressure. So the question is, no, we can't rely on that. You still need your mammograms.
Okay, then I have another question. Are you aware of any studies of plant-derived extracts being tested against neuroendocrine tumors? In particular, Apigen and Siliben and Genistein?
Not many. So the only study, and this is a whole different topic. So as you know, a lot of these the plant-based sort of herbal medications have not been tested, and partly because there's just no one who is willing to fund the trials that we need to properly test this. There will be a study looking at a plant extract for something I think it's called like black seeds or something. It's very common in Northern Africa and the Middle East, and it actually has possibly some cancer as activities against cancer. I heard that a hospital in Cleveland is going to start the study on it, but we need more studies on like this. But there's just no one willing to fund them.
Okay, so then related to that, have you ever had any patients whose tumors got smaller? Because I'm taking some of these extracts and mine are getting smaller.
Yeah, so then the question is really, if you're not, a lot of patients who are taking those things are getting other therapy, and then it's very hard to say what is actually doing work. So is it the treatment, like chemotherapy or the PRT, or is it the extract you're taking? If you're not taking anything else and things are looking smaller, that would definitely get my attention.
I'm not taking anything else. I never have for
No,
4 years.
and this has nothing to do with neuroendocrine tumors, but a few years ago, I had a patient who had a different type of a cancer who was on some herbal medications, and we saw that her tumor markers actually came down. I can't remember what it was. And tumors didn't grow for some time, and the tumor markers actually came down for some time, and then started growing again. So we were thinking maybe there was something in you were taking that actually had some activity against the tumor. So we should definitely, I'd be curious to know what you're taking. That's
I'll put it in the chat if you want to see it. Yeah.
Oh, okay, very good. So I'll take a look at that. Okay, so any recent studies on optimal sequencing of PRT? Hold your thought, we will get there. So there is a talk, I'll have a slide on that. So that is really one of the big questions here. So if there are no other questions, I think I can possibly just resume my presentation here, and then we'll just take a little break and take more questions. So here we should have our Mayo Net team again, and I'm just going to move on. So about so this is essentially our team, and we actually are really happy that we have 2 dietitians and the social worker now. So and we're hopefully going to get the pharmacist soon, and so the team is getting bigger, and they do work with some other tumor types as well. So and this is the way things work at Mayo, for those who don't know it. So after the initial referral, we decide to where this patient should go. Most patients will be screened by one of us in medical oncology. We look to see what has been done, what needs to be done, and then we set up a visit with all the needed tests. And some people have had such good testing at home, they don't need any. Others will need updates on their test, and then we make sure that we have you meet with the specialties that you really need to meet with. And so at the first visit, you'll get to meet the NET team. Oftentimes, one of our surgeons will have the radiology and pathology done by the time, and which is crucial for us to getting the diagnosis correct. And then we involve the others like nuclear medicine, gastroenterology, lung specialists, and so on and so forth. So these are the questions I ask myself at the first visit. When I see one of you in an initial consultation, I always ask myself, did we get the diagnosis right? This is where we need pathology and radiology. And about 20% of time, and these are not data from Mayo, I don't have these data yet, eventually I will, but these are data from Europe, that at one of the large European centers, I think in Germany, they looked at the new referrals of patients with neuroendocrine tumors and found that 20% of patients actually had the diagnosis wrong, sometimes like majorly wrong, sometimes just a minor thing, but a lot of them actually were not getting the ideal therapy for the correct diagnosis. So these are rare tumors, and for someone a pathologist who rarely sees this, it might be hard to get the diagnosis right. So then the next question I ask myself is, what is the stage of the cancer? Do we have all the necessary scans? Have they all been done, or do we need to do more scans? We're increasingly doing dotatate PET MRI or gallium-68 or copper-64 PET MRI here. I will say that scanner, it's not needed for everyone, but when we do it, it really blows the competition out of the water. So there is no neuroendocrine tumor scan that looks anything like it, but not everyone needs it. And then, do we have everything we need to recommend on therapy? So, are we aiming for cure, or are we thinking of controlling the tumor? And then most importantly, and this has to do with the patient, what are their goals for the treatment and what are their wishes? Because obviously we will not do anything unless you are all on board with it. So things to consider before starting the treatment is that, do we really need the treatment now? And what kind of treatment do we is indicated? We have to consider what we call financial toxicity. Some of these treatments are very, very expensive. For women of reproductive age, we got to consider reproductive toxicity. Some of these medications are absolutely not safe for in pregnancy, and then long-term toxicities. And we need to discuss the risk of leukemia from PRRT, which we'll get to in a little bit, and things of that nature. So, and again, it's really a team approach. So most of the time we can make the decision in oncology, but a lot of times I may have told you this already in the clinic. So sometimes you come see me and you expect that I will have a really good plan, and I'll tell you, I really don't. I need to take your case to the tumor board, I need to show this to the surgeons and the radiologists, and then we'll come up with a plan. So let's see, there is. Okay, so thanks for sending the information on the plant extract here. I just saw it pop up there. Okay. So moving on. So yeah, why the tumor board? So just because getting more brains in the room work better. So we do this every other week now, and we might actually have to do this weekly because we're just having more and more patients. This is virtual, and we have typically about 30 to 40 physicians and advanced practice providers present in the room of all the different specialties, and we discuss about 5 to 7 cases. Typically never more than 7 cases. So everyone gets a really good and thorough discussion, and then whoever presents the case at tumor board is responsible to follow up with the patient at the next visit, or if it's something urgent, we do it just over the phone. So now I'm going to talk about some of the new things happening in neuroendocrine therapy and this, or neoplasm therapy, and this will be a little technical. So probably most importantly is that one size does not fit all. So for a lot of scenarios in neuroendocrine neoplasms, we have several different options. So different drugs, surgeries, embolizations, whatnot. And sometimes we have a few options that are all probably equally good. And your local oncologist may have suggested something, I may have suggested something different, but we both may be perfectly appropriate options and equally effective. So we have to take into account what you want to do.
You're
And
not moving.
was there a question there, or
Moving.
long and short-term side effects, the cost, and obviously convenience as well. So a few clinical trials that have been published in the last year that you may or may not be aware of. So this was a large study in the US, 150 patients almost, with pancreatic neuroendocrine tumors, where patients were either given capecitabine and temozolomide or temozolomide alone. And this study showed, these are called the progression-free survival curves, and this study showed that the patients who got the combination of capecitabine and temozolomide, they on average got almost 23 months without tumor growth, while those who got temozolomide alone only got 14 months. So this just confirmed that the cape-tem is better than temozolomide alone, but some people just don't tolerate the capecitabine. This is probably not going to change much for us. So this was a study looking at pancreatic neuroendocrine tumors, comparing Afinitor or everolimus with an old chemotherapy called streptozocin. And essentially what they were looking at is that, should we start with Afinitor first, or should we start with streptozocin first and then switch to the other one if the tumors were growing? And essentially, this study showed that these are both good options. Going back to the sequencing of treatments for these two things, the Afinitor or the streptozocin, doesn't really matter which one you start first, as long as you get the second one later. But I will say this, that the Afinitor is much easier for most people than streptozocin is. This study, and these are complex slides, so I'll just go through these quickly. So this study was also trying to look at, what are we supposed to do when someone with pancreatic neuroendocrine tumor who's been on lanreotide drug triotide and now the tumors are growing? Should we give them PRRT, or should we give them Sutent or sunitinib? So this is to the question that was asked there before. So what is the best treatment? And this study was done in France, and I can't remember how many patients were on this. There were quite a few, and there were. Yeah, so I can't remember the exact number, but as you can see on these curves, the patients who got the PRT, that's the blue curve here, and at 12 months, 80% of the patients a year later from starting the treatment did not have tumor growth, while in the sunitinib or Sutent arm, 60% of the patients had tumor growth at 1 year. So this showed that if you have a well-differentiated pancreatic neuroendocrine tumor, PRT is a better option than sunitinib, but that does not mean sunitinib is a bad option. It just means PRT is a better option. So the take-home points here from these studies is that cape-tem is better than temozolomide alone. There's no difference in the Afinitor versus streptozocin, but streptozocin has higher side effects. And then for patients with pancreatic neuroendocrine tumors that are growing on somatostatin analog therapy, such as octreotide or lanreotide, PRT seems to be better or more effective. So a couple of trials in poorly differentiated neuroendocrine carcinoma. I'll go through these fairly quickly. So this was a study that looked at 58 patients with growing neuroendocrine carcinoma. They were randomized to either a drug called the nanoliposomal irinotecan with 5-FU and glucoburn, or a drug called docetaxel. And this study just showed that this nanoliposomal irinotecan was maybe a little bit better, but there was not much of a difference. So life expectancy in those who got the nanoliposomal irinotecan was on average 9 months versus 5 months for docetaxel. So not much of a difference, but definitely a difference. So I'll go through that quickly here. This study looked at chemotherapy called FOLFIRI with a drug called Avastin in patients who had previously received chemotherapy, and looking to see if this FOLFIRI chemotherapy could be made even better by adding this drug called bevacizumab or Avastin. And this study showed there was really no difference there by adding the Avastin. So FOLFIRI alone is what we do. And just go through that quickly. I'm going to skip through this here. and this year, because those are trials that don't really apply to most people. So, but this is what I wanted to talk to you about. So a couple of things here with advances in radionuclide therapy or PRRT. And this is only one slide on alpha particle therapy. Many of you have heard me or someone else talk about alpha particle therapy. So alpha particle therapy is the new generation of PRRT. So this is, we think this is the new Lutathera, and it's not available yet easily. There's one place in Houston, Excel Diagnostics, that has been doing this in clinical trials, and a few other places have been doing these trials. But a lot of these trials are going to come in the future, I think, including at least 2 of them to Mayo. So one study looked at a thing called actinium-225 with capecitabine. This was a study from India. 91 patients, 63% of them had previous Lutathera, 22% had prior chemotherapy. And a third of them were in pretty rough shape with this what's called ECOG performance status of 2 to 3. We're talking people who were in bed or in the recliner for much of the day. And so they were given this PRRT with alpha particle therapy. And for those who had previously had PRRT and the Lutathera, and it was no longer working, the median overall survival or the life expectancy was about 26 months. Keep in mind that these people were in really, really bad shape. So we think this might actually work much better in those who are healthier. And then those who had what's called the progression-free survival, the time that takes the tumors to actually grow, was also pretty respectable at the 30 months. And what's that? And then 50% of them had tumor shrinkage. And these pictures here on the right, this is from a different alpha particle study done in Texas. 20 patients treated with this 212 lead dotamtate. This is a new drug. This is not available yet, and you can see all of those black dots here are metastases in the spine and in the liver, we can see, and in lymph nodes down in the pelvis, and almost a complete response. This person here had a large tumor in the left lung. We can see that black thing here in the lung, and got treated with his treatment, and everything is gone. So these are probably the 2 best patients on this study, but this is really encouraging. And we'll get into that here when I tell you a little bit more about the trials that are coming. But this is what I wanted to talk to you about. These are probably 2 things that happened last year where that show that sometimes less is more. So first of them had to do with localized pancreatic neurotumors that are small, less than 2 centimeters, so less than 2/3 of an inch. So for most patients,
the speaker today
can be observed. We don't have to do anything about these. We can just wait. And there was a big study led by Italian surgeons. They looked at 500 patients with small pancreatic neurotumors, and they were able to show that we can observe or not treat for years without having to do anything. So now some of our patients who come in with a new diagnosis of a small pancreatic neurotumor, they will say, we're not going to do anything. We know it's there, but we're not going to do anything. Among those 500 patients, 400 of them had no surgery, and 3 patients died. Among of those 400 patients, 3 patients died in the time they were following them up, and none of them from a neurotumor. They just died from other things. And the other really important study was just published a few weeks ago, and that was looking at small tumors, neurotumors in the appendix. And essentially, that study showed that you only need a simple appendectomy and not a big surgery called right hemicolectomy. So the question, though, that's unanswered is that how often do they have to come in for scans? And so how often do we do the blood tests and things of that nature? And we don't really know yet. So typically we follow people with the pancreatic neurotumors. We scan them once a year. So I'm going to pause here again before we go into the last section, which is about the trials that we have open at Mayo. So any questions here? So from anyone?
Yes, I'm curious is that if you happen to know what the fees are for an MRI versus the CT, and can the dye that's used in the CT, can you see what you need to see without the dye? You know,
So,
that's-
yeah, so
Mhm.
good question. So as for the fees and costs, so MRI is probably a little bit more expensive. I don't know the exact numbers.
Mhm.
I will tell you this, that a CT of the abdomen without contrast is nearly a worthless study. And so it tells us, in neuroendocrine tumors, tells us next to nothing. The everything on the CT hinges on the contrast. So, and it has to be super carefully done. And if you do the contrast, if you give it too late or too early with a CT, you're going to lose out on the quality very, very quickly. And if there's one thing I learned during the COVID pandemic, when we were doing a lot of telemedicine, a lot of relying on scans not done at Mayo, a lot of scans done at other places that they're not used to seeing neuroendocrine tumors have very, very poor contrast timing. And we had to repeat so many CT scans. People came to us and said, I just had a CT scan last week. And we told them, it's a bad CT. We can't use it. And
What was poorly timed? What do you mean by poorly
the
timed?
time when they infused it, when they put the contrast in.
Okay,
So because really the moment the contrast goes in, we should run you through the scanner, and that's called arterial phase.
okay.
And you really have to go, they really have to start spinning the scanner literally seconds after the contrast goes in. And then as you have seen, there's a little bit of a pause, and then you go through the scanner again. And that's called the venous phase, and we need both. Many scans on the outside only have a venous phase because it's quicker to get that. You're not in the scanner for as long, but it's not good enough for us. And so that's the importance. We can get by with an MRI without contrast. MRI without contrast is definitely useful. It's not nearly as good as MRI with contrast. If we're looking for small liver tumors, we always need it.
Okay, thank you, Doctor.
So we have a few questions in the comments there. So if you have had PRRT, will you be able to try the newer versions? Yes, and we have a whole slide on that. So that is actually very important. And on the slide of the alpha PRRT, I read that there was a worse outcome with prior PRRT. That remains to be seen. So I think what that really means is that if you have had prior PRRT, you've probably had the neuroendocrine tumor for a longer time, and it might be a more aggressive tumor. So yes, it looks like you based on the little we know so far, that if you have alpha particle PRRT after having had a regular PRRT with Lutathera, your myeloid is probably not going to be as long as if you had never had PRRT before. So, but keep in mind that was only a small study, less than 100 patients. So I think we'll get more information soon. And then we have the last question in the comments here: are somatostatin receptors on tumors considered to be peptide receptors? Yeah, that's so these are what's called so these are peptide receptors in the sense that they bind to peptides. So these are called transmembrane receptors. That means that they go across the layer of the membrane of the cell and into the cell, and that's how they carry these signals into the cells. And the peptide name in PRRT comes from the part that actually binds to the receptor. That's the octreotide, or the which is what we use in the PRRT. So that's where that comes from. So any other questions before we move into the last sections? We can maybe just.
Dr. Thor, I have a question. Asking for a friend who's so PRRT, we've had that already, but it was canceled a couple of times in December due to availability. Has that availability been addressed? And is it just worth waiting for the alpha if you're a candidate? Or can you speak to that a little bit?
Yeah, I definitely can. So it all depends on the situation, and sometimes we have to wait. So what has happened with the PRRT, there have been some availability issues. And some of you may have been, especially if anyone was getting PRRT around May or June last year, there were 2 months where we could not get any PRRT because there was something happened in the factories that made the PRRT. They were worried there might be some contamination and the product wouldn't be good, so they shut down all production for like 6 or 8 weeks. Thankfully, finding out there was nothing wrong. So, but that just shows you that they really, Novartis that owns Lutathera was super careful about it. But that said, we are running into some availability issues. And we've talked to the company, Novartis, or AAA is another name for the company that owns Lutathera. So, and we've sort of voiced our displeasure with this. And why is it that we can't get the product? And they say sometimes it's because of availability, sometimes it's just because there's just so much needed of the drug that they can't keep up. And I think another cause for this is that the PRRT or PRRT-like therapy is now approved for prostate cancer. And prostate cancer is probably like 10 times more common than neuroendocrine tumors. And now a lot of the lutetium that's being made is actually going to prostate cancer patients. But last I heard from Novartis, they say we have enough for everyone. And then the last comment there would be regarding availability because of the prostate cancer treatment. We've had, and some of you may have seen this already, we're having a harder time getting patients into the treatment units at Mayo because they're always full. So that's why we're getting bigger unit. So we just opened a new treatment unit, and we have there is a plan of expanding the number of treatment beds, so we can actually really physically accommodate people. But sometimes it's okay to wait. So if there is a question about waiting for alpha particle study, I think that would be a really good question to bring up with your with a treating physician, and we would just look at the scans. And there are some people who have said, yeah, let's just wait and see if we can get you on the alpha particle study. And then, well, if I go into some of the other questions there, if you had a liver resection done for primary liver neuroendocrine tumor or NET, and the tumors return to the metastatic, and then the tumors return to the metastatic liver tumors are unknown origin. You did lanreotide or octreotide injections, and the tumors are still growing in the liver. What would be the next treatment? So here we actually have a number of options. So the first question would always be, has this case been presented at tumor board? I would ask the surgeons, is this something where we can get the tumors out? I would ask the radiologists at tumor board, can we do embolization? And we almost exclusively do what's called bland embolization and not radioembolization. No SIR spheres or Y90 spheres, because we think that may, in a lot of people, harm the liver in the long run. And we don't do it. Some others do, and it's probably okay to do in most patients, but we just decided not to do it. So then we typically have a lot of different treatment options after octreotide or lanreotide. If it's an unknown primary tumor, we have Afinitor, we have PRRT with Lutathera, we possibly have the cabinet study, we have some other treatments that are not approved by FDA. So we definitely have options. And then there is, what can you say about the liver tumors depleting the body of tryptophan so that there is not enough available to cross the blood-brain barrier and be converted to serotonin in the brain? This actually is a really interesting question, and we finally have some data on this. So serotonin is very important for brain function. It's one of what's called the neurotransmitter, and it is somewhat associated with depression and psychiatric disorders. And there was a study from the University of Toronto, just published a few months ago. They looked at how common psychiatric diseases are in patients with neuroendocrine tumors. And they found out there wasn't much of a difference. So they compared like depression and anxiety in patients with neuroendocrine tumors to patients with colon cancer. So both were patients who were going through cancer therapy, because obviously going through therapy is very stressful. And they found out that the patients who have a lot of serotonin production, so possibly depleting the body of tryptophan, they were maybe slightly more likely to be diagnosed with severe depression. There more work needs to be done, but it is possible that the serotonin production by the tumor or depletion of some other things could play into depression and other psychiatric disorders. So stay tuned. We'll have some more information on that. So I think I'll just go into the last section here before we take questions. And so we should have some of the, should have the slides up again. So I'm going to run through a few clinical trials. So some of them are open. So we talked about cabinet, so I'll skip that. So that trial is open at Mayo, probably will be for another year or two. So, and that's applicable to a lot of different patients with neuroendocrine tumors. So always ask your physician at any time when the tumors are growing, ask the question, is a trial the right thing for me?
Okay.
So this study doesn't have a name yet, and Alliance is what's called a cooperative group. It's a group of multiple different hospitals and clinics in the U.S., really all over the U.S. And they are looking at what's called sequencing here. So in this study, patients with pancreatic neuroendocrine tumors who have had octreotide or lanreotide, so sandostatin or lanreotide in the past, plus another drug, either Sutent or everolimus or cabozantinib on the cabinet trial. Here, the patients will be randomized to either CAPE-TEM, capecitabine temozolomide, or Lutathera for 4 treatments, the standard treatment here. And the primary endpoint is what's called progression-free survival. Essentially, how long can we control the tumors? Is CAPE-TEM better than PRRT? So this study just opened and is not quite ready at Mayo, but in the next few weeks, this study will be open for patients with pancreatic neuroendocrine tumors after tumor growth on octreotide or lanreotide and either Sutent or cabozantinib. So this is, and I'll often hear this complaint for people with lung nets. Why is no one ever doing trials in patients with lung nets? So in this study, we're looking at PRRT in patients with lung nets. So this can either be untreated patients or patients who had at least one prior therapy, either which typically would be chemotherapy or injection therapy with octreotide or lanreotide. And here patients will be randomized to either PRRT for 4 treatments or Afinitor. So these, we'll have that all covered. This study, and some of you may be familiar with this study called NETTER-2. So this one was looking at PRRT versus double dose octreotide in patients with grade 2 and grade 3 neuroendocrine tumors. This study is actually completed in the sense that no more patients are allowed on the study. It's done. We're just waiting for data. So this study is now in a closed status, and we're just waiting for the first data to come out. And then we have this study essentially replaced it. So this is a study called COMPOSE, and this is open at Mayo now. So in this study, patients with grade 2 or grade 3 well-differentiated neuroendocrine tumors, they have to have KSH7 15% or more, and they may have had no therapy or one type of therapy before. And here they are given either 6 cycles of lutetium-177 DOTA-TOC or etotriotide. This is slightly different than Lutathera. So instead of 4 treatments, it's 6 treatments. This is a drug that's been available in Europe for a long time and seems to be effective. And here, the comparison will be either CAPE-TEM or everolimus or known as Afinitor or FOLFOX. So let's say if you're appropriate for the study, you will be randomized to either PRRT with lutetium DOTA-TOC or what's called the comparator arm. And then we will pick of those 3 options, we will pick the one that is most appropriate for you. So that trial is ongoing, and we already have a few patients on it. So this is a trial I wanted to let you know of. So this is only applies to a small number of patients, mostly those who just got diagnosed. So this is self-administered octreotide. So this drug called CAM 2029 is a new formulation of sandostatin. And it's suitable for injection by the patient or the caregiver. It comes in a pre-filled syringe or a pen, super easy to administer. So the way this is done is that it's given by the patient, him or herself, under the skin. And it's a randomized study. So patients will have to have tumors that light up on a dotatate or gallium PET. And they may not have had more than 6 months of prior long-acting somatostatin analog therapy. And it's a little complex how this works. And I'll walk you through this. So there will be 300 patients worldwide, and there are about 110 or 120 on the study so far, and from multiple different European, American, from Canada, the US, European countries, and some Asian countries on this. So the patients will be randomized to either CAM 2029 every other week, sorry. And the first 1 or 2 injections are done at Mayo with supervision, and then the patients learn how to do it themselves. Or they get standard sandostatin or lanreotide. And if the tumor is growing, this PD here, we actually have the option of doubling the dose of the CAM 2029 to once a week, self-administered. And if there's again tumor growth, then we have to find something else. So essentially, we're testing this self-administered octreotide against regular octreotide or regular lanreotide. And there are 2 important things with this study. Number one, if this works, we may have a self-administered drug effective, and patients may not have to come to the clinic more than once every 3 to 6 months, if that works. Number 2, and this is more of a question, it is possible, we don't know it yet, it is possible that this CAM 2029 is actually better. And I think a lot of our patients would say, I would much rather self-administer every 2 weeks or even every week with a tiny little needle and a pen than having to drive into the clinic to get a larger injection into my buttock. So we'll have to see where this goes. So this study is going to be open at Mayo. Probably will be open here for the rest of this year, I would think. It's actually accruing pretty briskly worldwide, so probably won't stay open forever. So the other one, and I want to tell you about this study, this is opening, I think, this week or next. So this is a drug that has a weird name called coltizoltine. So this is a pill drug that targets the somatostatin receptor, the same receptor we're trying to target with the injections. So here, the whole idea is to switch or to be able to treat patients with a pill drug instead of an injection. So this is a drug that works for some other diseases where we use similar drugs like octreotide and lanreotide. But to go on this study, this particular study, there will be other studies of the drug coming. You have to have carcinoid syndrome with diarrhea or flushing. If you never had diarrhea or flushing, you're not going to be available. You're not going to be eligible for this. So this only applies to small bowel neuroendocrine tumors. And the 5-HIA test has to be elevated on at least 1 occasion. And patients can be newly diagnosed or previously treated, but if you are on injections that control your symptoms, and this is where people get a little uneasy about this, you will have to be willing to stop the treatment you're on, stop the injections, let the symptoms come back so that you can go on the study. So the study is going to look to see if we can control the symptoms. And if we can control the symptoms with a pill drug, we can probably also control the tumor. This is a complex slide. This just shows you how this works. So I'll walk you through this quickly. So this is for patients already on octreotide or lanreotide. If you come to the clinic and you're interested in this, we talk about your symptoms, and then we talk about stopping the injections and waiting for up to 12 weeks for the symptoms to come back, and then go on the study drug. And this is the study flow. And so we're almost to the end of the presentation. So we do the screening with 2 or 3 visits, making sure you have the symptoms. And then half of the patients get 40 milligram tablets, half of them get 80 milligram tablets. Both groups have the option of adding another 40 milligrams if needed. And if this works in controlling the symptoms, we can do what's called an open label extension for almost a year, where you can stay on the pill drug for almost a year. After a year, you'll probably have to go back to your shots. So really the whole idea with this study is to try to see if we can get the patients treated with a pill instead of monthly shots. So soon to open at Mayo. These are my last 2 slides. This is a study called Action 1. This is our first alpha particle trial opening. So here patients will have to have prior Lutathera, so standard PRRT, and there must be tumor growth, but after 3 months or more from the last PRRT. And they have to have growing tumors, have to have previous PRRT, and the tumors have to light up on a PET scan. And they have to be willing to receive one of the 3 what's called standard of care options. So patients will be randomized to this alpha particle PRRT for treatment, or everolimus, sunitinib, or high dose octreotide or lanreotide. So this study will have about 200 or 300 patients worldwide. I think this study will probably close quickly. I think a lot of patients will be interested in this, and we expect to open this study hopefully in June or July. And then the good thing about this study, if you get randomized and you don't get the alpha particle therapy, you get the standard of care with one of these 3 options here, and the tumors grow, you can actually cross over to the alpha particle treatment. And so even if you don't get it the first time around, you'll get it the second time around. And then actually, yeah, so I'll have some questions, but before I go there, there's another study with this lead-212 PRRT. I can't talk about it much yet, but we will have another study, which will be a phase 2 study. So everyone gets lead PRRT. And I don't know all of the details of the study, but I think that would be a nice study for those who cannot go on Action 1. And I think, if I have to predict, I think the alpha particle treatments are going to really be a game changer in management of neuroendocrine tumors. So that takes me to the end of the presentation. So we still have, I think, some time for questions.
I have a question, Dr. Thor.
Mhm.
It's about the PRRT therapy and what was it? Oh, leukemia, the chances of developing leukemia. Was it, did I hear that it was 3 or 4% per treatment, or is that overall?
Overall, so great question. So really good question. So 3% risk of leukemia overall. And and it typically happens within 5 to 6 years of completing the treatment. And there are now some thoughts, and I don't want to scare everyone, but there are now some concerns if you do PRRT and get CAPTEM either before or after, the risk may be doubled or tripled. So the risk may be as high as 6 to 10%. But then I will also say that for a lot of patients, if we're talking 6 to 10% risk of leukemia in the next 5 years with PRRT, a lot of our patients probably would not have 5 years if they didn't get the PRRT. So I will say for some of our patients, especially for the more aggressive tumors, a lot of our patients think, yeah, it's a risk, it's real, but the risk of not doing the PRRT is higher.
Okay. Thank you.
You're welcome. So looks like we have a couple of one more question. So, and if a couple of more questions. So keep them coming. So if you had a Whipple, would you recommend the liver ablation? If not, what would you recommend for removing liver tumors? And I've had PRRT, so this is a great question. So if you have a Whipple, and then obviously a part of the pancreas was removed, and there's a lot of sort of rerouting and sort of plumbing that's being done to connect the small bowel to the liver and the bile duct and everything. So now if we do ablation of the liver, you're at increased risk of getting an abscess, so an infection. So we don't like ablation or embolization after a Whipple. But if we absolutely have to, we can, and then we typically put people on antibiotics for a month or 6 weeks. Sometimes you can do surgery to remove the liver tumors. So, for example, I had a patient here who was from out of state, actually quite a ways away, and she had been told that she had a Whipple and had liver tumors, and she had been told by her surgeon that if we did surgery for the liver tumor, she would get the infection and she would probably die from the infection. And she was really afraid of doing that. And we said, and it's safe to do. So one of our surgeons took her to the OR, removed all of the tumors from the liver, and there was never an infection. So so it can be done, but you just have to be really careful. So we don't like doing ablations or embolizations. We can if we need to. Surgery can often be done. So here's a study on, or a question on artificial intelligence or AI for sequencing of treatments. Great question. No data yet, but honestly, I think we're going to see more and more of this in the future. So where AI is taking us in oncology is anybody's guess, but it's probably taking us somewhere. And so here, can Mayo remove a large lymph node with a laparoscopic surgery? Dr. Howe wants open surgery, and I know Dr. Howe well. He's probably one of the best surgeons I know, and it's a fast growing. It all depends on location. So, for example, we had a patient who came from out west, from one of the mountain states, and he had a tricky lymph node that was nearly behind the duodenum, and it was tricky. And he had been told by some really good surgeons that this had to be an open surgery. And he met with one of our relatively recently hired surgeon who's still super experienced, Dr. Susan Warner. She came to us from California a year ago. And so she did a robotic resection, got everything out, and discharged him after 2 days. So if you have, and I tell this to all of my patients, whether they see surgery here, it's all, if a surgeon is recommending a very large open procedure and you're interested in a smaller procedure, like a robotic or laparoscopic, it's always good to get another opinion. Same thing if you see me and you don't like my opinion, you have to go get another opinion. And it's very, very important to have the opportunity to get another opinion. So I think it's possible. It all depends on the location and the type of the tumor, but certainly something we'd be happy to consider at Mayo. So what is the current thought about bone mats? That's a really good question. So I'll give you a little bit of a background here. So when I started doing this almost 20 years ago, we didn't really think much of bone mats in neuroendocrine tumors. We could never see them. And then we got gallium-68 PET scans in 2015 and 2016. And now we're finding bone mats all the time. So tumors in the bones. So of course, the tumors were always there. We just never knew they were there. And then we've also seen that almost no one seems to have fractures with these bone tumors, but some people do. And we're just completing a study, all 3 Mayo sites, led by Mayo, Florida, but also Arizona and Minnesota. We're looking at our bone metastasis population, and we're actually seeing that there is a real risk of fractures. So if there's only just a few bone mats and they're small and they're not causing pain, we can probably just watch them. But for larger bone mats, growing bone mats that are starting to chip away the structural sort of component of the bone, what's called the cortical bone that gives you the bone strength, then we may want to do radiation treatment or some other treatments or bone strengthening drugs. So definitely you are going to learn a lot more about bone metastases. But I will say for most patients, bone metastases are very, very common, and they typically don't cause any major problems. So then can NET patients be blood or organ donors? I actually asked this question this weekend. And the person I asked didn't know. And last I knew, they were not. And I think cancer is still not patients with cancer are still not allowed to donate blood. And I will say that the regulations for blood donation in the US are a little weird. So, for example, I lived in Scotland for 3 months in 1993. I cannot donate blood in the US because I might have mad cow disease. So so I always donated blood in Iceland in med school, mainly to get cookies. And so I cannot, I've never been able to donate in the US, and it really irritates me because I always donated. And so hopefully that's going to change. And then the next question here is, can peanuts metastasize to the lungs? And they can. So, but one thing, yeah, rare. I'd say probably less than 5% go to the lungs. Definitely less than 10%, but they definitely can. But I will also say, if you have pancreatic neuroendocrine tumors that are also in the lungs, make sure that we're not dealing with MEN1. So because MEN1 patients can have a primary neuroendocrine tumor in the lungs. So then we're actually looking at a tumor in the pancreas and the tumor in the lung. And I saw one such patient last week or the week before that. So, but it can go there. And does having been on Afinitor cause future PRT to be less effective? Thankfully, no evidence suggesting that. So I have not, that I've tried to monitor this literature really closely. I have not seen anything saying that prior Afinitor decreases the efficacy of future PRT. So if your doctor is wanting you to, or recommending Afinitor to you, and you're thinking, well, I might have to do a PRT in the future, don't worry about it. The Afinitor will definitely not increase the leukemia risk. Nothing suggests that right now, so that should be okay. So yeah, good question. If a patient is reassigned to your PA, does the PA converse with you about the patient care? Always. But I will also say that our PA, especially Rachel Eyring, has been doing this for, I don't know, 6 years now. I sometimes joke about this, that she probably knows more about neuroendocrine tumors than 95% of oncologists in the US. And that's because this is all she does. And I will say she is a true neuroendocrine tumor expert, to the point that she is starting to get involved in how the treatment guidelines and things like that. So so she's really good. But that said, we always talk. So we sit next to each other in the workroom, and we're constantly talking the entire day, and about everyone. So if it's like something super simple, she might not have to let me know right away, but we always regroup at the beginning of the morning or beginning of the day, and then throughout the day we talk. It seems like there are more studies from pancreatic NETs. Yes, isn't that irritating? So, why is this? So it seems like one of the reasons is that there are more things that work for pancreatic NETs. So that's why we've seen more studies for pancreatic NETs. I will say, of all of the future studies I've looked at, both studies we're opening and studies I'm seeing, we're probably going to see less and less of the studies focusing on pancreatic NETs. But I think what people thought, yeah, we have pancreatic NETs, let's just try to make our study as clean as possible by not mixing together like different tumor types. But it's been, so I think we'll see more studies that are not just focusing on pancreatic NETs. Okay, moving on. So is there any consensus on how to best treat lymph node involvement? No, there isn't really. Other than to say, if you're doing surgery for the primary tumor and you can get the lymph nodes out, you really should. And this especially applies to the small bowel neuroendocrine tumors that have what's called mesenteric lymph nodes. Those are the lymph nodes that sit sort of in the middle of your abdomen, and they can over time wrap themselves around some of the blood vessels, the arteries and veins, and cause some problems, even bowel obstruction. So we try to remove them. But some lymph nodes in certain locations where we know they're never going to push on anything or cause any damage or even cause pain, we can ignore, not ignore in the sense of forgetting about them. We can just say, well, leave them be. We're not going to do anything there. But if we're doing surgery and we can get the what's called the regional lymph nodes out, we should. So that's the end of the questions, the comment, but the microphone is open.
Hello.
These are all outstanding questions. This is what I always say. Whenever I meet with any of you, I always walk away with like 2 or 3 research ideas. So, and that's why, and you may not know this, so you probably don't know this, but when the National Cancer Institute is funding a new trial for a neuroendocrine tumor, there is actually a patient advocate on the committee. So, which is a new thing in neuroendocrine tumors. Now, and some of you may know Josh Mailman, and so he's very commonly there. And there are some other patient advocates that are actually starting to participate. And now, when we're creating a clinical trial, we, the physicians, we have certain things that we're scientifically interested in, but now we're actually building in also questions coming from the patient community, because they want to know about side effects and toxicity and quality of life and things like that. Oh, we have new questions. Nice. Okay, so yeah, thank you for having me. That's yeah, I'll just say that. So what is better, octreotide or lanreotide? This is a great question. So I will tell you, if you just look at the drugs, they are the same. I will say there's no difference. But as you know, the octreotide needs to be injected into a muscle in your buttock called the gluteal muscle. And depending on how we're put together, it can be difficult to get the injection in there. Some people have such anatomy that it's just hard to get the needle in there. Some people have more padding on the outside and may be hard to get the needle in there. And there was an amazing study done years, probably 10 years ago now. This was at MD Anderson, which is arguably one of the best cancer centers in the world. It's sort of the same, I'd say, same quality as Mayo. It's in Texas. They do a fantastic job in everything they do. So they looked at the success rate of injecting octreotide into the muscle at MD Anderson with really good nurses, and they found out that half the time the injections were not going where they needed to go. So they retrained their nurses, and now they got the number up to like 75 or 80%. So, and then there was another study years ago from Ireland that was looking at not at octreotide, but other medications that have to be injected into the muscle. And here, what they did, this is actually crazy. Everyone who was getting injection, they injected 1 milliliter of air with the medication. And then they put the people in what's called a low dose CT scanner and just scanned their buttocks and to see where the air bubble ended up. Half the time it ended up in the fat. And these were injections that were meant to go into the muscle. So the octreotide, although it's a drug just as good as lanreotide is, up to half the time it's incorrectly injected. And
that's what I thought.
I may have shown some of you this in the clinic. So I sometimes tell people, I'm always looking at people's butts on the screen. And that's because I want to see where the injections are going. So the lanreotide, those of you who are on lanreotide, you can feel those little lumps under the skin. They are sometimes annoying and irritating, but they are there for a reason. They got injected because that's where the lanreotide should go, and it gets from the tissue, from the fat into the bloodstream. But the octreotide, you shouldn't be able to feel a lump because the octreotide injection is much, much deeper. So I think the lanreotide is easier to do, but this is where I hope that new drug, the self-administered octreotide, will come in strong. So hopefully that trial will pan out. And I have no stake in that trial at all, I'll tell you. And that trial also is, because that is injected under the skin, it's a very low volume, and it's actually in a new formulation that the company tells me does not form lumps. Okay. We'll see if that's true. So at least what they told me. So moving on, so has there been, octreotide is sandostatin. Yeah, sorry. So lanreotide, that's the actual drug name. The brand name for lanreotide is somatuline or somatuline. The brand name for octreotide is sandostatin. And you may have heard there's a generic lanreotide out there, and I think it's probably every bit as good. I don't know yet, because we haven't really started using it much, but the Europeans have been using it, I think, for a year now, and I have heard no concerns other than the injection is a little more tricky. So any progress in treating NETs with genetic engineering? No. So this really not. But what I will say is that I just saw the grants that were given last week by the Neuroendocrine Tumor Research Foundation, and they are actually starting to fund those kinds of studies now. So I think no progress I'm aware of yet. Much better genetic understanding of the tumors. I think we're going to see some movement in that sphere now. So my concern with octreotide is that it's a powder, and you can and can you get the full amount of the dose? Great question. So some of you may know, if you let the octreotide sit in the syringe too long, it almost turns into concrete. But typically the way the syringe is filled accounts for that, so that you should, assuming it's being correctly injected into the muscle, you should get all of the drug in the syringe. So side effects from long-term use of lanreotide or octreotide, two major side effects. Neither of them is like super harmful, but you need to know of. There's a risk of diabetes, and we finally have data on that from England. So there's probably about 10 to 15% risk of causing diabetes in someone who is starting octreotide or lanreotide. So always watch out for symptoms like thirst and having to pee a lot and things like that. And your doctor should be checking that. The other thing is that, as many of you may know, that the lanreotide and octreotide mess up your digestive system a little bit. So now you're not digesting fat. So undigested fat comes out on the other end as like a loose yellow, foul-smelling stools that often float in the toilet bowl, have like oil slick on the water. Sorry, I've got to talk about these things, and that is a really annoying side effect that can't be oftentimes completely fixed with pancreatic enzymes. And I am actually telling my patients now, and this is what I learned from patients. So start with over-the-counter enzymes. So just go to the drugstore. Don't get probiotics. Probiotics are great. You can take them too if you want. And but it has to say pancreatic enzymes like pancrease or pancreolipase or protease, anything that ends with ASE, or ASE is an enzyme, like pancreatic, like one of those enzymes. And you have to take them with the meals, because they have to mix in with the food when you eat. So if you realize, I forgot to take my enzymes and now it's like 2 hours after I ate, that's not going to help, because the food is now already undigested in your small bowel. And so it has to go down with your food, and just try it out. And a lot of my patients are doing this. I have no particular suggestions regarding any particular brands. It seems like everyone seems to find a brand that works for them. And if it doesn't, we'll have to go to something like Creon. So what happens if the lanreotide injection gets injected into the same area where there are lumps? Yes, that's a really good question. So theoretically, it might not get absorbed as well, but I think that's really only theoretically. So probably no harm if it gets injected into another lump, but I wouldn't, we can avoid it, great. If it happens, probably no harm. And they will also say this, that if your nurse accidentally injects the lanreotide into muscle, goes too deep, that's actually okay. So it works just as well. It just doesn't have to go all the way in there. But if they accidentally push the needle a little too far, ends up in the muscle, that's fine. So no worries about that. So I got octreotide into my hip. Is that better in the butt? No. So that's as long as they get the octreotide into the muscle. And here is what I would really want to take a look at the CT scan. So sometimes when people say I got it in the hip, sometimes it's just a little bit too far out to get into the muscle. But sometimes it's perfectly injected. And I saw someone, can't remember, I wish I remembered, from a relatively small injection center in I think in Minnesota or in North Dakota, and octreotide, and over years, every single injection seemed to go into the muscle. So whoever did that was totally amazing. So some people are just really good at what they do. And so here's another question. Since Creon is so expensive, yeah, isn't it? So it's do you recommend the over-the-counter products? Yes, that is exactly what I was saying. Creon is getting so expensive, and we've been very vocal with the company and telling them about that. Creon used to be a generic, or there was a generic pancreatic enzyme drug. When I started doing this, it was much less expensive. Now we're left with 3 brands: Creon, Zenpep, and Biocase, and they're all expensive. The company that makes Creon has an assistance program, and very few people seem to tap into it. So if you're coming here to see me and there's a high cost of Creon, talk to us about the assistance program. If you're seeing someone else who's giving you Creon, ask them about the assistance program. I'm blanking on the name of the company, but they heard us loud and clear. And so that something has to be done. And as for the here's one suggestion. So digest gold. So okay, I'm taking notes here. So and there's one, now I remember one brand. I'm not like partial to any brands, but one of my patients takes something that I think is called Puritan's Pride. And I looked it up, and there were like 10 different digestive enzymes. And after I looked it up, he had left the office, so I couldn't really ask him which one he goes with. So next time he comes back, I'm going to try to remember to ask him which one of them do you go with. And then there was someone else in my office not too long ago who was on something different, a brand I had never heard of. I think he or she got from Amazon, and that seemed to work fine too. So Medicare, okay, Medicare patients do not qualify for. I did not know that. I just did not know that. And so I think it's probably time for us to meet up with the Creon reps again. Because this is, yeah, it is incredibly expensive. Any other questions? So the microphone is open.
What time do we have to leave?
Right now.
Okay, should we go?
Happy, yep, that's right. That's yeah, okay. Okay. So I think it might be that. I'll have to look it up. I know I have the email from them somewhere. Alrighty. So yeah, that's all I had today. So if there was anything in particular, let's say if there was a more like a narrow topic or something you wanted to talk about at Northwoods Nets, I'd be happy to talk. I know Rachel is happy to come talk to some of the nuclear medicine people. I know we had Tuba Kendi a few years ago talk, and so definitely we're happy to come talk with you.
Great. Well, thank you, Dr. Thor, for spending.
Okay, there's someone asking, where are you located? I'm in Rochester, Minnesota. So the smaller Rochester. Okay, thank you very much.
Yeah, thank you, Dr. Thor.
Bye.
Enjoy the rest of your day.
And yeah, thank you. Thank you for
Bye-bye.
taking.
Thank you.
Thank you, everybody.